I'm Dr. Latika Narula. I'm the Director of the Simulation Program and Director of Simulation and Teaching Excellence at CAMH. I'm very excited to be able to host my friend and colleague, Dr. Sean Cross, who will be presenting today on the innovations in medical psychiatry, improving care of patients with both physical and mental illness. So before I formally introduce Dr. Cross, I'm going to begin with some housekeeping. For those of you here at CAMH in the room, you'll see that we're live broadcasting Sean's presentation to our MPA partner sites. So bear with us as you see some of our team troubleshooting throughout the webinar. And for those of you on the webcast, welcome and thank you for joining us. If you can hear me, then congratulations, we're all set to begin our webinar today. Please use the chat box in the webinar room to communicate with our moderators who ask a question or let us know if there's any issues or any errors that we need to be mindful of as we proceed. This is a multimedia presentation, so we'll try our best to make available to you all the aspects of it remotely. But again, if there's any technical issues, rest assured that we'll share the recording and the entire webinar via the Medical Psychiatry Alliance website. And of course, today's presentation is hosted by the Medical Psychiatry Alliance, so I'd like to take a moment to promote the upcoming Medical Psychiatry Alliance conference with its theme, for which is new approaches to care for patients with physical and severe mental illness. Our conference is going to be held on October the 6th, 2017, and will feature a number of presentations from diverse professionals and perspectives. So you can visit and find out more details about the conference on the Medical Psychiatry website, which is www.medpsychalliance.com for more information on how to register for this innovative and exciting conference. We'll be live tweeting this event, so feel free to join the online discussion and use the hashtag EduAchieve. And we'll have time at the end for some questions from the audience here, but also those who are joining via the webcast. So I'd like to formally introduce and welcome Dr. Sean Cross, who is a consultant in liaison psychiatry in London at the Maudsley and is also the clinical director of the King's Health Partners Mind and Body Program and director of the Maudsley Simulation Centre, which is the UK's first simulation training centre focusing solely on mental health issues with the aim of improving service for all who are affected and impacted by mental health issues. Dr. Cross is passionate about delivering high-quality education and training to improve the care and experience of service users. So please join me in welcoming Dr. Sean Cross.
Thanks very much indeed, Latika, and thanks very much for the invite to come over here. And it's nice to see some familiar faces in the room as well, and have that slightly spooky feeling that there might be some familiar faces somewhere down the road at a distant webcam site as well. It's fantastic to be here because of the continuing link around the aims both of the simulation stuff here, and I realize we've got quite a few sim people in the room, as well as the MPA. As far as I'm concerned, when I first heard about the MPA a couple of years ago, it was one of those delightful moments where you just realize that there's someone else in the world trying to tackle the same sorts of things that you're trying to tackle, because there aren't that many places in the world that are trying to do something about this. And so my overview today in this seminar is going to be trying to give a very sort of high-level, broad overview of both sort of clinical and managerial service development, with a little bit around education and training. So the education training sim stuff will come towards the end of this talk in the last 20 minutes or so, because I think it's key. I continue to think it's key in helping address many of the problems that come about as a result of the way in which we run our services. But I'm here all week and we'll be doing engaged in a series of different activities culminating in some wonderful kind of faculty development stuff at the end of the week, which I hope some people will come along to. So, with no further ado, the next next 15 minutes or so, I just want to give you a very brief overview of the Maudsley and King's Health Partners, which is where I work in London, and a little bit of a view about the problem, because I know that the stuff that we're trying to deal with is very similar to that which the MPA is grappling with here. And then about half of my presentation will be around service innovation and development, and I've got a series of about 5 or 6 different little projects that I want to tell you about, and then we'll come to talk about some sim stuff, and I'll show you a few videos at the end. I want to just, for those of you who've never worked in London or never worked in the UK before, the Maudsley is a sort of name and a brand that gets kind of bandied around quite a lot. It has reach in different places, and so I'll just give you a little bit of an overview about where we are coming from and where I'm coming from. We become quite passionate and say we've got over 800 years worth of delivery of mental health services in London. One of the original hospital sites in central London. It's moved around a little bit now and is now part of our hospital trust and network. Originally the Bethlehem, then the Bethlem, and it's where you end up getting the word Bedlam from as well, a sort of abbreviation of that. And then the other sort of big part of our organisation is this thing here, which is basically where I work, which is the Maudsley Hospital, which was an innovative and radical intervention around 100 years ago, where a gentleman, this guy here, who remained anonymous for quite some time, gave £30,000, which is a considerable amount of money back then, to form a hospital to actually deal with mental health problems that didn't result in someone being sequestered out in one of the asylums on the outskirts of the city, which were rampant right across Europe at the time. A completely radical and innovative idea that would offer outpatient treatments and follow-up for people with mental health problems. And so the Maudsley was found, and again, exactly at the time of the First World War, dealt with a little bit of, many of the problems of soldiers coming back from the First World War, but now has become one of the premier sites for mental health service development in the UK. And of course now we're also twinned with what was the Maudsley Medical School, and some of you will be aware of it, which is the IOP, recently rebranded as the IOPPN. And so together we're a hospital network and a university associated with a very large output around mental health and mental and physical health. And the reason that I just want to give you that sort of broad brush at the beginning is because what we're trying to do now in the sort of next phase of the story of the Maudsley over many, many years, which is King's Health Partners, which is a grouping of general hospitals, so it's Guy's and St Thomas's, King's College Hospital, and also the Maudsley, with a chunk of southeast London that you see in the bottom corner of that map, trying to bring together a series of different hospitals looking at a whole range of different problems that arise. And of course, one of the key components of this, if you're going to bring healthcare providers together, is looking at these two or three incredible aims that are at the heart of the MPA as well, that we're grappling with, which is around mental and physical healthcare problems. So when our Academic Health Science Centre was formed 6 years ago, we had a mind and body program. At that point, it was quite transactional in nature. People would do very cool, incredible bits of work in diabetes or in sort of pain. They'd look for a research grant. They'd get some numbers. They'd get some kind of outcomes, and did some quite incredible work. But over the last couple of years, what we've tried to do, and this is where you'll see imitations in what you're doing here in Ontario with the MPA, is say, how do you take some of that incredible work that can happen either in a time-limited way or just in one single pathway and grip an entire system? Because this is key, I think, to trying to deal with some of these abysmal outcomes. And there's nothing up here that is going to be a surprise to anyone in the room here. So over the last year, I've been put in place as clinical director of what we're calling our Mind and Body program. And this is our label for what you might call medical psychiatry, or what you might call even wider than medical psychiatry, looking at sort of mental, physical interface issues. And so the key things for me that get me out of bed in the morning to try and do something about this are two patient outcomes. The first of which is that abysmal outcome that you have, that if you have a severe and enduring mental health problem, living in a high-income country in 2017, you're going to die somewhere between 13 and 20 years earlier than if you don't have it, from a disease that does not kill you. And the second thing, of course, is that much wider and growing group of disorders that there are around, all these long-term conditions. In England, we had a recent epidemiological study and found that we're somewhere between 15 and 16 million people with a single long-term condition. These are your diabetes, your hypertensions, your heart failures, your COPDs, all this kind of stuff. And we know that as soon as you overlay any kind of mental health problem on top of it, particularly the common mental disorders like depression and anxiety, then all your outcomes are worse. But what happens is with both of these particular conditions, you end up as a patient entering a healthcare system in which we provide services that are commissioned differently, provided for differently, and educated for differently. And so this is the key, this notion of how do you keep an eye, for me, how do you keep an eye on these generational outcomes, so over the next 10 or 20 years, how are we going to try and impact on these things, recognizing that the answer are going to be lots and lots of little incremental steps that you can take to try and knit together some of our pathways. And for those of you who have been down to Camberwell, which is the site of the IOP PN in the Maudsley, and this is the slide that I put up on all my talks because it's a fantastic metaphor. On one side of the road you've got King's College Hospital, and on the other side of the road you've got the Maudsley Hospital, and then you have this bloody great road that runs through the middle, the route of the number 68 bus, and for me this is the mental physical interface. This is the problem that I have in my life, and when I'm feeling most jaded about my job, I think more than anything else it's that I help people cross the road, and in doing that it's actually quite a tricky thing to do. But having that notion of basically trying to knit together services is increasingly seen as a really important thing to do. We've had reams and reams of reports, and I'm sure you get them here in Ontario and across Canada as well. They usually get labelled something like crossing boundaries, or the importance of being able to bring together different kinds of services. And the stuff up here from our perinatalists or OBGYN colleagues, emergency department, we've got the paediatric college at the bottom here as well. Everybody recognises that this is a major issue. The question is, what can you do about it? And so what we've done is we've set forward this thing called our Mind and Body Programme, and we have this is sort of the next two slides that I'm going to show you is our basic overview plan. We have a 20-year plan locally. All from our commissioners to primary care to secondary care are now signed up to this. In 20 years, these very simple aims, that if you have a severe and enduring physical health problem, we want to work out how we drive down your mortality rate and how we reduce morbidity associated with that particular disorder. And on the other side of the road, if you have any long-term condition, then you end up having professionals who are looking after your long-term condition who are not frightened of mental illness and who know what to do when someone comes up and has any kind of mental illness whatsoever. Very, very simple at one level and incredibly complex at the other when you start thinking about this mind-body dichotomy that we all sort of end up being enmeshed in. And we have a 1 to 5 and a 5-year program of what we're going to do. Locally in our hospital network, which is 2 big general hospitals and a mental health trust, quite large number of inpatients, and we see 4.2 million patient contacts every year. And that's just in secondary care in our little bit of South London, which is only 2 boroughs out of 32 boroughs in South London. 4.2 million contacts, and that doesn't even include anything in primary care, so that excludes anything from a family doctor seeing someone. And so this is a large number of contacts that are occurring within that healthcare system that is actually riven with this rift, with people coming at it from either I'm employed on one side or I'm employed on the other. And so at the very core of what we're trying to do is we want to introduce universal screening. A universal screening attempt so that what we're doing is we're looking for these common mental health problems that are around, and we'll pick up some of the severe and enduring mental health stuff as well, but really trying to get a grip on the anxiety and the depression problems that are rampant within our system. We then, in a very simple way that is incredibly complex to actually to roll out, we want to create a step care model everywhere. And then what we want to do is have the whole thing wrapped around with some education and learning. That's the sort of plan on a page elevator pitch for it. Sounds incredibly simple and it is super, super difficult to do. And what we're trying to do, what we've started to do over the last year, is lots of engagement. And the key part of what we're going to do is engage with our patients, because at the end of the day, when you get sort of tied up in much of this sort of managerial enmeshment around how we're going to institute sort of screening and development of our services and step care models within our services. Running 4 or 5 of the service user outreach focus groups that we've had just kind of it keeps it real. What people want is, you hear repeatedly all these I statements. I want to be able to see a doctor who knows everything that's going on. I want to be able to be in control. I don't want to be referred on to someone else to deal with something else that is intrinsic. If I've got diabetes and I'm struggling, I want someone in a diabetes pathway to help me with my struggle and not refer me on to a psychologist or a psychiatrist. And this is, I think, something that we should aspire to, absolutely. So I'm going to sort of talk you through a series of these little initiatives that are trying to incrementally do something about these multiple problems, whilst at the same time keeping an eye on that generational aim, that strategic aim of those 2 major outcomes that I was talking about before. IMPARTS is a fantastic project which has been running a couple of years and is now the screening tool arm of our Mind and Body program. So it states this wonderful kind of acronym. I can never remember it, so it has to have it written down somewhere. So integrating mental and physical healthcare research, training and services. So what it's attempting to do really is something very simple, which is put a screening tool into the pathways of someone ending up in a general hospital setting. So I'm referred because from my family practice into diabetes or heart failure or wherever it might be, you end up meeting a nurse, a senior nurse or a junior doctor or sometimes a consultant who basically starts to take a diabetes history. What we do is we're attempting to screen everyone before their arrival, with an iPad or with a phone in the room, and then for that information to flow to the patient who's actually, to the person who's actually about to see the patient. Sounds very simple, and we can get it to work in a very nice circumscribed way within that particular pathway. And what we want to do then is allow that information to flow. At the moment, as part of our whole program, the information goes to the person who sees you, but it doesn't flow around the wider healthcare network. But we have a plan to try and get it to do that in the next couple of years. And what we've tried to do with the IMPARTS program is say, okay, we're going to go in and wash your pathway, try and psychologize your pathway, put in a screening tool, offer you some training, but then withdraw. How much does it work at that point? How much are you able to say that anyone entering that pathway then is able to have a more holistic, integrated approach to their healthcare? A series of projects that we've got trying to measure that a little bit. And in some places, it's award-winning. We have these kind of, fantastic sort of nights every now and again. Dermatology won a BMJ award recently. But then you start looking at the numbers. And last year, award-winning as this kind of program was, 45 outpatient clinics at our hospitals locally. We screened 17,000 individual patients and around 30,000 screening contacts with people coming back again. It sounds fantastic until you put it against this 4.2 million patient contact that I told you about right at the very beginning. So even now, with all these attempts at trying to do something about this and allowing information to flow around, what we're doing is we're screening fewer than 0.5% of patient contacts. So our plan, my plan, over the next kind of 3 to 5 years is how do we take this and scale it? How do we take this so that it rolls out in every outpatient and the wards and, my God, the emergency department? As soon as you start doing it in the emergency department, it's going to be crazy to work out how to do that. And for all that information, not to just simply sit with a patient's pathway, but an informatics answer that allows the information to flow right across the healthcare network. It's going to be possible, but it's going to be hard. Other innovations that we've got sort of locally is a significant expansion in consultation liaison psychiatry. I'm not sure if this is happening in Canada or not, but there's been significant new investment from the UK government. It's one of the few areas that is actually sort of getting investment in healthcare at the moment. And that's because it's seen as a linchpin in being able to reduce costs. This is why investment is actually occurring. To be able to reduce the cost associated with patients' presence in the hospital, particularly the number of bed days that they will actually take up in a general hospital setting when they have any comorbid mental health associated with it as well. And the reason, there's a whole series of initiatives in the UK that have tried to sort of bring this about. One of the biggest was a study that occurred about sort of 5 or 6 years ago now, called the RAID study, which showed that for every £1 invested, £4 was actually saved. So for every dollar invested, $4 return if you have a decent consultation liaison psychiatry. And most of that saving came through bed days with the elderly, about getting people out from particularly into psychogeriatric services from general hospital services. It remains to be seen whether this investment is going to be a good one in the next kind of couple of years. But locally in King's Health Partners, we are now we now have some very fulsome liaison psychiatry services. And I'm going to tell you about another project that we're involved in, which links very much with liaison psychiatry services. And this is a national report that I wrote together with an acute physician colleague, and we ended up calling the report Treat as One. And it was an investigation of what happens when someone with any kind of comorbid mental and physical health problem in a general hospital setting, all the problems that come about as a result of someone being there. Problems with staff not knowing what to do, problems with security, problems with capacity, decision making, problems with all sorts of issues in terms of the lack of a smooth, quick, rapid, efficient, high-quality care pathway. And if you want to Google it and have a look at it, there are 22 recommendations that we're trying to implement locally. But I'm just going to show you just a tiny little bit of the data. There's reams and reams of data to highlight a couple of the systems issues, because this is what I'm here to kind of talk to you about today, really. It was quite a large study. Started off with a net of 11,000 and then 552 and very detailed case notes that were looked at with a range of different problems that people came in with. It was not an epidemiological study. We were trying to get people with a whole range of different with different presentations, and you'll see there's cardiovascular, surgical, respiratory problems in there as well, as you'll see across these. And you'll see that we also ended up with a lot of people, disproportionately high number of people with schizophrenia and severe depression. Again, it's not epidemiological. We're not looking for numbers of people coming through. We're just trying to throw the net wide to capture people with any mental health problems so that we test the system a little bit. And those systems repeatedly show this rift sort of everywhere you go. So this data is only a few months old, but you'll see this two very key things for me which kind of highlights this interface problem that we have, which results in, I think, poor care being offered, which is clinical record sharing, the gaps between the two lines in each of the hospital sites here. So this is both with local community hospitals, but also a raft of other hospitals. The number of people who are actually engaged in active clinical record sharing between the two sites is poor, abysmal. And so if you're a patient, if this is your parent, if this is your brother or sister entering here, then you start to see where some of the responsibility of the healthcare system is failing in being able to help someone navigate a successful care pathway. And this is even worse, I think. This is just a simple question around the discharge summary. If you end up going into one of our general hospitals with exacerbation of COPD or an infection or a degree of heart failure, whatever it might be, did your psychiatrist get a copy of your discharge summary with basic information on there? And you'll see the abysmal data that we have here. And so when you start thinking about how to link that stuff I was talking about earlier with our imparts and our screening and our data flow project, together with an increase in the number of people working with our system thinking about this, these are the kinds of things that we need to address. This is a sort of incremental intervention that has a possible that's going to have a possible result in really driving down those two medium-term outcomes that I was talking about. They're not directly linked, but what we did show here, not just as a sort of discharge summary, but what we did show here is that the quality of care offered to patients, if you had consultation liaison psychiatry service within your general hospital setting, was better than if you had no consultation liaison psychiatry service. And if you had a high-quality consultation liaison psychiatry service, then the good practice markers came out even more. So a disproportionately larger number of people were getting things like record sharing, were getting things like discharge summaries, following patients around. So it's an attempt at trying to incrementally show how these things can actually work. I'm going to pivot a little bit now to talk about some of our long-term conditions work rather than just the severe end. So this is the data that I was talking about earlier. Is those people with long-term conditions in England, not the whole of the UK, just in England, 15.4 million from a couple of years ago, and those people with mental disorder over 10 million now, and then the overlap pretty significant. And some survival curves, and these are now, they'll be very common in many particular pathways. This one for diabetes with the dreadful survival curve with depression and diabetes on the bottom, with a minimum of 30% of people with diabetes having depressive symptoms, and of course depression associated with both worse glycemic control, so all your physical health outcomes are worse, as well as having more complications and more bed days and more presentations to emergency services. And so a few years ago, my colleagues Khalida Ismail, who's a professor at the IOPPN, and Carol Gale, who's a diabetologist, set up a project that they call 3D4D, 3 dimensions for diabetes, and a radical, very sort of incredibly radical idea, which was about putting psychiatry and psychology and social work into the diabetes pathway. And so what happens is they will be in the room next door to be able to see patients directly, but they will also be doing MDM teaching and multidisciplinary meetings and just basically making the whole system work better. And so the 3D4D model was one in which it's about sort of embedding better liaison specialist services within your physical healthcare outcomes. There's a whole series of lots of papers that have been written on these projects, but I just wanted to sort of highlight some of the cost-benefit analysis that we did on this. And so, looking at one particular part of the pathway, what we got really was almost a 35% what you might call return on investment. So simply by having great outcome measures, people really like it. All the diabetologists really like it because they're dealing with all this. They're dealing with all the problems that they would have to refer on, and people go to the emergency department less. Their HbA1c is better. And they use fewer bed days if they are actually admitted. And so actually a cost saving, but we could not persuade our local commissioners to actually commission this service. They say 35% return on investment is not enough. And this is in a healthcare system that actually is virtually evidence-based free for much of the way we actually sort of commission services. And their challenge was basically, I don't want a diabetes model, I want a long-term conditions model. And so we took up the challenge. And this is where we're at the moment, because you look at any of these long-term conditions and these survival curves are there. This is not our local data, this is US data, but looking at both sort of emphysema, COPD, heart failure, and a whole range of other stuff, you get that same diabetic survival curve as well. You introduce depression and it's there. And again, 30 to 40% of our heart failure patients have depression. And so we now have a project which is just sort of up and running, which we're now calling 3 dimensions for long-term conditions, to basically scale up and take the model that we had with diabetes. We have embedding psychiatry and psychology within the pathway, the psychosocial pathway development, so that they're doing teaching, they're doing MDM work, and they're actually offering some direct clinical care as well. And these are our kind of psychiatrists, psychologists, who are now going to be embedded doing the same thing. So what I want to be able to do is within the next year to be able to show you some data, say the stuff that we've got from diabetes, can you do the same with heart failure, COPD, and hypertension as well. And I hope very much. Early data seems to be showing that we're doing exactly the same, which is both improving the pathway for patients, making staff feel a lot more confident by simply being there. So you're incrementally you're bridging that gap, that road, that metaphor that I showed you right at the very beginning, and you're saving money as well. And of course, what we're wanting to do is, this is a slightly sort of busy and complicated slide, but once you sort of look at it, you'll realize how simple it is, which is basically creating a step care model using that screening tool right at the very beginning. So PHQ-9 and GAD-7 is what we've basically landed on because they're so ubiquitous. Screening everybody who comes through and then working out where they would flow. And of course, what you want to be able to do is get as many people as possible to be seen as low as possible in any refer-on system. So someone coming into a diabetes clinic, someone coming into a heart failure clinic and having any adjustment problems or having any low-level depression and anxiety problems, you want that heart failure nurse or that diabetes nurse or that diabetologist or that or that cardiologist to deal with the problem and to feel confident to deal with the problem. But they've all been trained in this system that is basically has this rift there. So it's about having people who can reinforce and buttress. This is not the kind of thing that you ask someone to go on an e-learning package once and then it's fixed. It needs continual, constant nurturing and continual, constant reinforcement, which is why in the last little bit of this we're going to be focusing on some of the SIM training, because I really do think that's a significant answer. And then of course you create this step care model all the way up. The higher the numbers you go, it's more likely that you will end up having to either see someone or be referred on. As much as possible, having psychiatry and psychology within the pathway, that you will see someone within that pathway as well, and for that information to flow much more readily around. And of course, right at the very top are the incredibly complex high-cost patients, often very, very few of them, that need to be gripped in a much more assertive way so that you try and sort of drive down the amount of resources that are actually being used, because at the moment it's completely scattergun with people going all over the place. The question for a lot of this then, that I think is one that I'm really interested in, is should we be developing services, should we be developing psychology, psychiatry services that are tailored and specific for the disorder that someone has? So do you develop speciality as a diabetes psychiatry psychologist? Should you develop specialisms as a heart failure psychiatrist or psychologist, or should we be sending people to generic services? There's a huge tension in there, and this is where the conversation is at with our local commissioners, but also our academics as well, because we have a number of really quite cool examples of T for long-term conditions, and there's 3 up here that you see: multiple sclerosis, irritable bowel syndrome, and those who are on dialysis, and the expertise that is brought about by someone having particular training with a particular disorder. Do you need that, or is it generic? These are the questions that we're asking, and I think the answer is probably going to be, for some things you need specialism and for some things you need not. But how you develop these sort of multiple sort of ripple out services, do you need one specialist sort of person and multiple genericists, or do you need to embed lots of people within different pathways? I don't know. You're going to be getting some you're going to have some very strong views about that, I'm sure, within the MPA, and we'll hopefully get some data around it as well. Flip to the other side a little bit, because I haven't talked to anything really about this notion of better medical care within mental health services, but we have a series of programs around there as well. Psychiatry and Diabetes Service, which is our PODS service, actually takes diabetologists into our community mental health teams, where many of our patients are spending most of their time, and we'll have some data from this to show within the next 6 to 12 months as well. A series of other innovative initiatives around increasing exercise and monitoring steps and getting people to kind of do all sorts of things about sort of monitoring the amount of walking they're doing via community mental health teams, in a way that many people who've got their Fitbits or their kind of Apple Watches who are sat in this room, how do we take that into those people who have severe injury and mental health problems? So a range of different things. Happy to answer any questions on much of them, but I want really to focus for the next sort of 15 minutes or so just on education, because much of the stuff that I've been talking about is around recognising incredible complexity. And so if you have within this system differently commissioned, separately provided for, separately educated for services, if you're dealing with someone with this comorbidity, and the last time you as a nurse or a doctor dealt with the mental health problem or the physical health problem 20 years ago when you were an undergrad, and you might have done one random CPD day or something like that. How do you start to enhance the skills, the confidence, and the ability to be able to manage the system better? And I think one of the answers is high quality educational intervention at a CPD level. We've scoped, I showed some of this data when I was here last time about trying to divide our healthcare workforce, which is 35,000, into 3 different levels. So we include all our receptionists and security guys and all the rest of it, those people who are not clinical, as well as those people who are generically clinical and then working in hotspot areas like diabetes or heart failure. And simulation training, I think, is key. And so just to sort of bring people up to speed on what we're doing, I'm just going to show you a kind of 3-minute video of, it's an animated video, the irony of kind of showing animation when actually what you're wanting to do is do something kind of high quality and high fidelity.
Supporting people with mental health issues through the healthcare system towards recovery and well-being can be challenging and complex. Knowing how to help and what to do can be difficult and stressful. So how do you train for these situations? Healthcare professionals are often trained via e-learning or en masse in a lecture room and instructed on how these challenging situations could be better managed. Experiential simulation is a much more powerful learning tool than these. With Maudsley Simulation, learners are placed in a painstakingly accurate staged environment, alongside trained actors who authentically portray a range of mental health problems. You simply do your job as you normally would, as you are embedded in the scenario that plays out in front of you. The situations are specifically tailored to your own clinical working environment, whether that's the ward, the GP surgery, or out in the community. It provides an interactive way for you to gain knowledge, skill, and experience in a safe learning environment, and provides a unique opportunity to train as an interprofessional group including doctors, nurses, and many others who provide care. We offer services as teams, so we should train as teams. A group of your fellow participants observe each scenario in the next room via live video link, so all the knowledge and experience gained is shared between everyone. After each scenario, there's a unique opportunity for reflection and insightful learning as a group, in a debrief supported by experienced facilitators and experts in a non-judgmental environment. Maudsley Simulation has over 40 different courses addressing mental health and mind-body programs. Research shows that simulation training is good at targeting human factor skills such as teamworking, communication, leadership, and others. To improve staff confidence in challenging and unfamiliar situations, mental health simulation is a great tool. To find out more, then get in touch with Maudsley Simulation.
I thought it was actually a bit of a surprise and quite different.
Previously it's been based on mannequins, where today was using real life and simulated patients who are played by actors.
It is brilliantly set up, the cameras are so discreet, the rooms do look like wards, they do look like offices.
So it's a place where we can get tips and tricks of the trade that we can try on, almost like a pair of new shoes or a hat.
It's an open environment with no judgment, you can make mistakes.
They actually have the chance to meet patients with these disorders without really meeting patients with these disorders. When they embrace the situation, they definitely learn from it.
It's really good working together peer-to-peer in a small group.
It definitely gives you good skills to take forward into your practice afterwards.
It's really interactive, it's a fun day, it's a great experience, it's a great learning environment.
Nothing bad can come from it, only good. Most people are nervous about it, and people have only been pleasantly surprised and taken away that unexpected, golden nugget. It's an enriching experience for all of us.
repeated hits and high quality hits, looking to try and address some of the problems that are pertinent for all the stuff that I've been talking about from a clinical perspective. And that is about knowing what's going on in someone else's environment, how to start thinking about team working, not just to include your own team, but other people's teams, how to start thinking about navigating this very complex system that all our patients and all our relatives end up dealing with. And the SIM stuff, the SIM component of this is fairly, I think, fairly crucial. We now at Maudsley SIM have brought through almost 5,000 staff in the last couple of years. And we've got a series of these day-long programs, which are about 44 programs that we have now. Many of them address mind and body issues. As you'll see here, they improve skills and confidence. Well, it's not to kind of believe about it. It's in an animated video in front of you. But what we're trying to do is measure the impact of these kind of educational and training interventions, but focusing very much on all the stuff that I've been talking about. And across the week, I have a series of meetings, both with Latika and hopefully many of the other SIM team who are here today, to work out how we measure this stuff. We have some initial data around if you start to bring together general hospital staff and mental health staff in a room and talk about patient problems. So simply sharing patient information, stories, case vignettes and these kinds of things. We've run a series of these day-long courses where we have sort of 50 or 60 people in a room. It's a much cheaper way of doing education and training versus running something like a simulation training. Just give up on it, guys. Running a simulation training, and we found in measuring that we can detect definite increases in the responsiveness of the ability for people to feel much more skilled in the ability to navigate these systems and to work in an interprofessional way. And we're going to be talking about some of this stuff as we go on during the week. Let me kind of sort of move on a little bit. And for those of you who are interested and who don't know very much about SIM, then you go to our website, which is Maudsley Simulation, and you'll find a series of our courses there. And it's this idea of recognizing that many people will enter our healthcare system and go to these different siloed blocks, so different hospitals or different organizations, often that have completely very different approaches to their education and training and don't have these patient outcomes in mind that I was talking about right at the very beginning. And so we've basically tried to work out where these junctures, where these mental physical interface junctures are, and then stick a course there. And then try and measure the ability of people to start thinking slightly differently. And at the moment, the major challenge that we've got is how to do this at scale. I think we're not doing things in a tiny way, but nor are we gripping our 35,000 workforce repeatedly every year. We're somewhere in between. So we've brought through around 5,000 staff, as I said, in the last couple of years, which is not insignificant, but nor is it a complete systems wash that we're talking about and that Benoit will be very interested in, being able to see genuine sort of systems change here. But I think there are ways that we're able to try and take this piece of work forward. And one of the joys of being here is that we've got someone else in Latika who's interested in trying to do this as well. We've started a nascent group, and we're now starting to publish a bit as well. So we had a sort of op-ed piece in Lancet Psychiatry around integrating mental health simulation into routine healthcare, and then we've got about half a dozen publications that you can see on our website over the last year, both looking at pre and post stuff, but also trying to do some systems grip as well, and happy to share those publications with you. What I was going to do was show a series of these other sort of very short videos for less than a minute each, but I'm going to walk you through them a little bit before taking some questions at the end, really. One of the things that we will often do as well, and this is something that I hope you will experiment with here at CAMH and your general hospitals as well, is taking out your equipment, your video cameras and your ability to create a simulated environment and your actors and your simulated patients or whatever you want to use, and taking them into real life clinical environment. So this is the emergency department that I work in here at King's College Hospital. It's one of the busiest in London. It's one that's been incredibly busy over the last sort of few months with the major incidents that have come in. But every single day, we're a major trauma centre, and every single day we deal with a very large number of complex mental health cases coming through. Probably about 2 or 3% of everything that comes through the door is primarily mental health, until you start to think of it in the way that I did with the epidemiology at the very beginning, and then you'll see that 20, 30, 40% of the stuff that's coming through the door has a mental health component to the presentation, whether it's anxiety associated with a COPD exacerbation or someone who is just kind of struggling and their diabetic control has now spun out of control. And so taking our simulated tech team out into the emergency department is something we've done on several occasions, and we've also now managed to persuade a whole series of other emergency departments. There's a swathe of them across the south of England, in Kent, Surrey and Sussex, so these are all the beautiful counties on the outskirts of London. 14 emergency departments down there that have now purchased our simulation training packages, because there's a recognition, and this is something that you'll see, I think, when you're doing sim, is that when you go into this environment, if you go in there and you just do, if you run a seminar, you could easily go into the emergency department, run a seminar, and then sort of just disappear, and no one would ever know that it's actually been on, apart from the few people who came to your seminar. There's such drama associated with doing a simulated environment, a simulated package in a real-life clinical environment, that it has quite a considerable ripple-out effect in the rest of the emergency department. And we're trying to sort of measure that as well. But taking these things and going into an we also have a great course, one of our most successful courses. We brought through hundreds of staff this year alone for those dealing with perinatal mental health problems. So we have OBGYNs together with our health visitors and others offering care to recent mothers, together with mental health care professionals as well. An ideal setting for a simulated course. And then we also, our techs go to incredible lengths to actually sort of make our simulated environment actually look like a little old lady's housing environment. And you'll see here that we have both police and ambulance services, and we've brought through several hundred local police officers and paramedics as well, focusing on mental health, to try and do that entire systems grip. The idea of the simulation, the idea of the simulation intervention, I think, is about trying to actually recognize this incredible complexity, and we have now the ability to be able to offer an equally complex educational intervention that keeps people's attention, that people are willing to sign up to, because all they have to do is to play themselves when they end up in these environments, and we're now starting to do it at scale. We want to be able to scale even more. Projects around VR, projects around how to take our learning from a simulation day with only 12 or 24 people there into a much wider group of people. All these things we're pushing at the boundaries of as well. But I think a key component to much of the clinical complexity is going to be recognizing that we need to meet it with a complex educational intervention as well. Sorry you didn't get the videos, but you're very welcome to come and look at them after. And that brings us up to 10 to 12, which is kind of bang on time in order to take a question or two for Latika. Is that right? Thank you.
Thank you, Sean. Sorry we didn't get the videos up, but we will post everything on the Medical Psychiatry Alliance after today, so hopefully we can kind of embed the videos and share those broadly, so stay tuned for that. So we'll take a few questions. I can help moderate. We don't have a microphone in the room, so if there's any questions in the room, I'll just repeat them for everyone who's on webcast. But to get us started, there's one question from Andrew Johnson, who's the manager of our Client and Family Education Department. So his question is to you, Dr. Cross. Are you involving patients and other families in designing simulations, for supporting training of standardized patients?
The answer to both of them is yes, and in different ways depending on the course that is being offered. So we use an active faculty rather than. I mean, you may well have some actors who have previously had lived experiences, but they're all actually professionally trained actors as well who come in. And in order to be an actor on any of our courses, you need to have been on one of our faculty development days, and that is a two-day minimum course that has been designed, developed, and delivered by both our staff and service users as well. So we'll have a day, a few hours on what it's like to hear voices, a few hours to what it's like to be incredibly depressed, or what it's like to be manic, and we have the patient voice there is a very strong one, and with some of our courses as well, we have in different ways depending on the course involvement too.
Thank you. Any questions from anyone in the room?
So I have a question. In Canada, we have a challenge engaging the primary care physician. You know, the MD, the staff from the office, the social worker want to learn. The MD of that vision, they are too busy, and you showed us those very nice slides showing like they don't exchange chart. They view those problems are peripheral. We know they are not, but their perception is that it's not their problem. Yep. So any tip?
So I'll just repeat the question, and correct me if I'm wrong, Benoit, but how do we engage primary care physicians when a lot of them perceive this to be a problem outside of their maybe scope of practice?
Yeah, it's a difficult one. So when you're running a program that is relatively volunteeristic, then what you get are those people who are most enthusiastic about it. It's certainly not all our courses are like that, and we have a sufficiently large number of courses now that are paid for by hospitals or paid for by commissioners. Sort of recognizing the problem, seeing one of our courses as being a potential solution to that, and then buying, I want 10 of these in order to roll out across our entire network. So you're much more likely to get that person coming through the door going, I'm here because I was told to be here, rather than I'm here because I want to be here. So it's a very different dynamic that gets set up. Now, we don't collect data separately from those who've been told to be there and those that want to be there to try and compare them, although it might be an interesting sort of look at the outcomes. But it doesn't, anecdotally, even those people who've been told to be there, you can, invariably, people feel as though it's a valuable day. So the question becomes, how do you get more of those people in the room? The only answer to that is to mandate it. That it has to be. So you either pick a few hotspots and then be able to get a little bit of outcome data associated with it, but basically you don't get a choice in this.
But those physicians are employed.
Yeah.
But they are employed by the health trust. They are salaried and employed.
Yeah.
The challenge we have here is those physicians, by and large, are not employed.
Yeah.
And they are paid fee for service. So
yeah.
We do offer those schools free, so
yeah.
But they have to.
So this is the major challenge, isn't it? So I'd say that was a challenge of the executive medical director of the MPA to work out kind of how to fix it. But I don't know, because it almost becomes a commissioning problem, because they're like mini providers, really, aren't they? So if you're basically saying if no one can work in this particular environment unless they meet certain competencies or unless they meet certain, and then you can put in there whatever you like, whether that's a day-long course or something very sort of basic, which I'm sure you would have, or you want to be more aspirational about what you put in there. But there's some of it which is going to be stick, and some of it which is going to be sort of enticing. That sounds like a stick thing to me.
I agree with you. By the way, once you get them through the door, normal people seeing all the data you presented, start paying attention, and if you have a good quality course, they enjoy it. But it's soft to present.
Yeah.
So there's one other question here in the room. Go ahead.
Yeah. I'm very curious about what you said at the beginning of the talk, talking about that people who are getting to the simulation training, when they get exposed to that, what we learn is that you have to do a lot of those real examples in practice to be able to actually change behavior. one simulation training is not enough. So unless you set up the system in which they have no choice but to face those changes all the time. So I wonder if you have any comment on that.
So just to summarize, so I guess trying to, balance between simulation training, which is kind of isolated and a one-off, with changing the system, which is kind of what people see in practice.
Yeah, it's hard. It's very tough to do, but I think that the one way is to try and reduce that siloed work, which is, I suppose, if you think of the difference between the work that I'm doing, I'm a clinician as opposed to an educationalist, and what you need is both sort of doing this together. And so I think you need you need clinician buy-up. Buy into this whole process, and then to be able to link it in a series of, we're trying to develop local competency frameworks, and being able to say, if you are a junior doctor, a junior trainee here, or a nurse in the first 5 years, then you will come to this many courses. Trying to do that in the current healthcare system that we have in the UK with no money is very hard, but we're still trying to do it sort of aspirationally, because what you want to do is link it with the e-learning package that you have and the basic outflow and all the posters that are in the clinical environments. Some of this is about marketing, which is a mind and body, mind and body, mind and body, mind and body, and also this is a mind and body educational intervention. So it's not seen as this random thing that you might get to go on, but is part of a whole systems change.
Thank you. I'll quickly take a question from webcast from Ivan Silver, VP of Education. Have you been using virtual reality formats with your simulation program?
Hi, Ivan. I hope to see you this week. Hope you're well. Routinely, no. We have ideas of how to try and do this, and I want to run some studies, and so it'd be good to talk to you about it, because I know you're thinking about it over here as well. But at the moment, routinely, no.
Okay, a few more questions from webcast, if there's none from the room. I thought I saw a hand up over there. Go ahead.
Matej Zarowski, I'm a consult liaison psychiatrist at a hospital just down the street. Do you have a split like we do in Canada? Like here, this is a primarily psychiatric hospital. We have general hospitals like where you work. Do you have the same kind of split in the UK?
So you're wondering about if you have the same split between general and psychiatric hospital in the UK?
Yeah, absolutely. So we're the same tribe, so it's nice to meet you, Matej. So I'm a consultation liaison psychiatrist as well. So yes, so I sit in a general hospital, but I'm employed by the mental health organisation. The general hospital actually has no management ability over me. So I'm employed by the Maudsley, but I don't have an office or anything in Maudsley. I sit in King's College Hospital, and that's the common model in the UK.
And then when you do these kinds of presentations, because you do very much sound like this is a consultation liaison kind of talk where we should have endocrinologists, we should have neurologists and other individuals as such in the audience, and yet here it's mostly psychiatric. Is this sort of the audience that you envision?
So you give very similar talks in lots of different places, trying to get everybody together in one place across that diverse range of specialities is very difficult. It's very difficult to do in the UK. And it'd be very difficult to do here, I'm sure, as well. This has come, so if you think of it, it's almost like we're talking about something that is very sort of passionate to me, incredibly important to me, but I'm also coming at it from a slightly different angle. So I'm not coming at it from a development of consultation psychiatry angle, or I would be in the wrong place. We're coming at it from an educational interventionist angle via the MPA, and I just happen to do all this consultation liaison, psychiatry type stuff. And so this seminar really is one of a series of things that are going on during the week, particularly around education and training. But this was an ability of me to basically, but look, we're doing all this other kind of clinical stuff. But you're right, we're on in many ways, for much of what I'm talking about, the wrong side of the road.
We'll take one more question from webcast, and then the remaining questions to everybody who posed them on webcast will maybe respond on Twitter, so we can send that out afterward. So the last question is from Patty at Trillium Health Partners. Are there risks in screening everyone without a guaranteed intervention for those who screen positive?
Yeah, absolutely. That's a key thing. We shouldn't be screening anybody if you're unable to do a service chase, which means that we have so of those numbers that I showed you, we screened 33,000 patient contacts in the last year, there was a very detailed step care model of what to do. There's your go-to person, the referral pathways, etc., etc. So in trying to move from doing that to our 4.2 million, we're not going to do it in one big bang. We're going to do it over several incremental but quite significant steps in the next few years. But yeah, I think you'll cause way more kind of carnage in your pathways if you start looking for something and then not being able to respond to it.